Okay, we talked this morning about COPD in general. We talked about PE, about the use of things like markers, like the BNP, what you do with troponins, and we talked about beta agonists, anticholinergics, and steroids. And to be honest, we covered the vast majority of the information you need to know about managing COPD. There are two and a half other sort of big things that might be in your armamentarium to treat somebody with COPD. The first section we're going to get into here is the idea of antibiotics. Okay, so we're talking now about this sort of next step, which is antibiotics. Now, I was upstairs while you guys were off skiing, I was upstairs and I pulled up that GOLD criteria I told you about. But you get one free download, and they start charging, because of course the world needs to charge for everything. But you get one free download of their guidelines. And I went through it to sort of see what they recommend on these things, just to make sure I was telling you the correct stuff. And the quote they say as far as antibiotic use is, if a patient has an exacerbation characterized by increase in dyspnea and sputum volume with, quote, purulent, unquote, sputum, you should consider using antibiotics during that exacerbation, which I think is not unreasonable. But the first two papers in here do raise a little bit of an eyebrow about what does purulent sputum actually mean. By the way, we deal with a lot of body fluids in medicine. One of my least favorite is sputum. Any body fluid that like sticks and stretches is just kind of gross. Sputum is nasty business. And if you ask a person to give you sputum, what they tend to do is go, pfft. I mean, they give you spit, right? If you want sputum, first of all, sputum needs to be from down here. So they got to hock up a good one for you. They have to do that horrible old man down the hallway, to get it out of there, to get you sputum that's really sputum, right? That's what they really need to do. And then, and think about the patients that come in and, I love the ones that hand you the tissue. Here you go, doc, this is what I'm coughing up. Or give you the emesis basin with like the last 12 hours collected in there of what they've managed to gooby up there for you. Part of this is what they call bad, sputum, icky sputum, purulent sputum. Is that what you would call purulent sputum? And what does it mean? And the first two papers try to look at this. And to be honest with you, I think these are entertaining. I'm not sure it's going to help me a whole lot in what I decide to do with a COPDer. But they basically try to divide sputum in the first paper into mucoid sputum versus truly purulent sputum. God bless them, they got a paper out of it. Good for them. They did find that if somebody really has truly, they're coughing up pus, there are bugs in there. That's helpful. If it was mucoid, they were less likely, but have at it, good for them. The second paper basically said that if they do cough up what looks to be, sort of a different color change from what they're used to, that it doesn't necessarily imply a significant bacterial load. It does often imply an infection, which is what we're going to transition into next.